Good afternoon, class. I'm going to spend just a few minutes reviewing some information I jotted down last night regarding chapters 3, 4, and 5 that it's going to be included on your midterm review or for your midterm test. And one of the things I want to talk to you about just right off the bat, I guess, is thinking about the marginal decision rule. And what we're talking about in marginal decision rule, what's going to be the impact of adding an additional unit either to the supply curve that slopes upward, or the demand curve that slopes downward. So if you're a producer, you're thinking about what's going to be the marginal cost of adding it. If you're a consumer, you're going to think about I'm looking at marginal cost and marginal benefit. So the marginal decision rule basically says if the marginal benefit of an activity is greater than the marginal cost, you do it. The marginal benefit is less than the marginal cost, you don't do it, or you reduce the activity. And if the marginal benefit is equal to the marginal cost, then we're maximizing net benefits, especially in the market and to society. So with this marginal benefit rule, you're always thinking, because and it doesn't matter whether you're a buyer or seller, go back to the 3 pillars of just basic economics: opportunity cost, self-interest and optimization, decisions at the margin. Marginal decision rule impacts decisions at the margin. And also think about, as you are as we kind of go through this in healthcare, health economics, whether you want to look at health economics, healthcare economics, it is based for the most part on your microeconomic principles. And that's why during these videos I talk about, go back to your microeconomic classes and think about what was said in those classes. And it's extremely important because we've been talking so far about the demand for health, the demand for healthcare, and for the economists, again, to simplify the complex environment that we work in, keep everything fixed except for prices and quantity demanded when you're looking at the downward sloping demand curve. And constantly invoking ceteris paribus, all of the things the same, all of the things unchanged. And what we're not allowing to move, we're talking about consumer preferences, we're talking about the price of related goods and services, we're talking about income and wealth. And keep in mind, income and wealth, especially in healthcare, is important. We're thinking about demographics, and again, a huge impact or huge demand shifter in healthcare. And then we're thinking about buyer expectations. And also, healthcare is no different than a lot of market economies. Individuals in positions of control and power are, again, back to some of the basic tenets of microeconomics. We're trying to figure out what to produce. We're trying to figure out how to produce it, trying to figure out for whom it's going to be produced. And then lastly, we're trying to keep some of our resources in reserve. So, and if you go back to the how piece of it, so the how piece of it is the production process, more or less. And if you remember, think about your production possibilities curve. And, we're talking about comparative advantage. And what do we always say about the production possibilities curve? There are 2 caveats that drive it. One, all of your resources have to be at full employment. And it's not just labor, it's labor, it's capital goods, or capital stock, it's natural resources, it's technology, and it's entrepreneurship. Those have to be at full employment, and it has to be an efficient production process. And if those 2 things are met, you're going to be setting with a comparative advantage on that production possibilities curve. And whether it's healthcare or any other market economy, there are some somewhat disconnects among these kind of four parameters or four pillars on economic thought here. Because once you've made the decision about what, and once you've made the decision about how, then your decision for whom is going to be driven by a lot of economic factors, but it might not necessarily be equitable economic factors. So I guess where I'm trying to get to, and especially that's why you'll have governments, trying to play in the healthcare market, is because there's as you go down through the what, the how, the for whom, and how to conserve resources, you may be doing it in such a manner that it's not equitably distributed among a consuming population. And especially if the government gets involved, they use normative, statements that, well, here's the way you should do it. Here's the way the world should function. Here's the way the market should function. Here's the way consumers should, consume these goods and services. But markets, if markets start to fail, that's when you have the government jumps in. And when it, initially, and if you go back to the topic on, must have been chapter 5, when we're talking about the market for health insurance. Health insurance started out, it was private, and the more it evolved into the private healthcare space. Remember, you had Arrow's article, written probably in late 50s, early 60s, published in 63, and then like in 65 and 6, you ended up with Medicare, Medicaid, Champus TRICARE. So again, government gets into the markets when they think there's an opportunity for market failure. And if you think about the healthcare market, and you think about a competitive market, you've got many buyers and sellers in the healthcare market, but issues with quality raises its ugly head, because as consumers of healthcare services, we can't go in and kick the tires. And I'm not sure you want to go in and kick the tires. In other words, you don't want to see 5 or 6 different healthcare providers. And it's okay to get second and third opinions. I'm all for that. But where it gets dicey is you start a treatment plan, and then you flip to another treatment plan, and you flip to another treatment plan. You just need to get your consultations done and decide on the best treatment plan for you, at least to start with. So, you have trouble kicking the tires. The benefits within the healthcare market, it impacts your healthcare status. People with health insurance, tend to overuse healthcare goods and services. I mean, that's pretty much it. If you just watch and talk to people, that becomes apparent fairly quickly. It's some individuals that have healthcare insurance, it's almost like going to the buffet line at Golden Corral. People walk into to a buffet, and they say, hey, I paid my money, I'm going to get my money's worth. And they gorge themselves. They just can't back away from the feedback. They can't leave that buffet line. And it's somewhat similar to healthcare, because you have individuals that have paid for health insurance, or they have health insurance as a benefit from their employer, and they're going to use it. They're going to take it as much as possible. They're going to get as much out of that healthcare benefit as they can. And then we talk about principal agency or principal agent issues, depending on how you want to phrase it. And it's basically buyers and sellers. And the problem you have with the principal agency, one of the main problems is asymmetric information. most people assume that their healthcare provider knows more than they do about treating a given healthcare illness. And I agree. I like to make that assumption. I'm not sure it always holds, but that's the way it should be. They've gone to medical school. They've gone to have a residency. They've, had an internship somewhere. They should know more than the average American about treating illnesses. It's difficult when you get into the healthcare situation to estimate marginal benefit and marginal cost, because as a consumer, you're not really sure what the marginal cost is. You know what your marginal benefit is. You can figure out your marginal benefit, and you can somewhat figure out your marginal cost. I've got a copay. I've got, my time is worth something, wear and tear on the car, gasoline, parking to get to the primary care doc. But a lot of individuals don't go that route. They don't think about, marginal benefit and marginal cost. And I'm not even sure a lot of providers get into those details. The provider and, governments, it's easier for them to do those calculations than the consumer. And then we talked a little bit about, your health status. In theory, if your health status goes up, your demand for medical services goes down. Or if your health status goes down, your demand for healthcare goods and services go up. And in theory, it's a negative correlation, as you would assume. Now, there are many examples of individuals that have maximized their health status and end up in a car wreck or disabled the rest of their lives. Or, you're reading these stories in the news about people hiking in natural parks and falling off a cliff, or, drowning or something. There's a lot of weird things, that can happen. But in theory and in general, again, I'm being a good economist, in theory and in general, or for the most part, as your health status goes up, your demand for medical services goes down. And then you're talking about, in healthcare especially, you get into those demand shifters. Remember the ones we talked about right when I started this video, things like income and expectations and, number of substitutes. Those are all demand shifters, and especially demographics. Don't forget, as we all get older, the demand for medical services especially just continues to increase. Why? Health status in general deteriorates as you get older. And it doesn't matter if you get out of, let's say you take this class and you graduate with, a master's in health administration, and you go to work, and it doesn't matter whether you go to work for a provider side of the house, you go to work for a government agency, you go to work for a health plan. And if you're in a position where you're having to make decisions on how to allocate resources within your team to maximize the marginal benefit of the organization that you work for, you're thinking about three things constantly: opportunity cost, decisions at the margin, self-interest, and optimization. There's just no way to get around that. So as you build your toolbox, and if you're thinking about getting into the healthcare environment, always keep that in mind. Go back to those three pillars that drive economic choice. Talk about, then we talk for, I guess, a fair amount about a person's good health. You want to live a long and healthy life. Healthier people are more productive in general. More productive, typically more income. If you're not having to miss work, if there's no constraints on what kind of, employment you have, all of those things could be a result of your health status and why you want to ensure that you continue to have good health. Again, don't ever forget normative and positive statements. Economists think in positive statements. This is how the world is. policymakers, government officials think in normative statements. This is how the world should be. And then also go back to when you're talking about supply and demand curves. Well, you know, economists, if we're a good economist, we are constantly talking about ceteris paribus. All things unchanged, all other things equal. And we talked for a few minutes in one of the classes. It may have been chapter 4, but we were talking about derived demand. And it's a derived demand is, you know, it's SID, it's supplier induced demand. It's demand for good or service generated for either a related or a different service. But typically in healthcare, what we're thinking about in SID, supplier induced demand or derived demand, just in general, we're thinking about, and a good example is, I go into my primary care doc. I've got having trouble breathing, a lot of cough, a lot of congestion. My primary care doc fumbles around for a while and finally says, well, you know, I think you may, you know, I don't think you have pneumonia, but let's be sure. And, you know, sends me down to have some blood work done. You know, I go, he's got a little radiology thing in his office. I get a chest x-ray. You know, he may have like a nutritionist sitting there, and he sends me to your nutritionist or your dietitian. Especially you'll see in dialysis centers or individuals with kidney issues, they're going to have a dietitian that's there talking to you about your diet, because your diet drives a lot of issues with your kidneys. But those are things you're thinking about derived demand. I go in there for an office visit. I go in there for a CPT code 99213, and that's just medium office visit with an established patient. And I come out of there with a laundry list of, needle pricks in my arm where they've drawn blood. You know, I've had my chest x-rayed, probably going to give me some pharmaceuticals. When I go to the pharmacy to get those picked up, those are all derived demands. There was no demand for that when I went into the doctor's office, but I walked out of there with a derived demand. And then we see a lot, and we talked about it, or I mentioned it in one of the videos. This is open enrollment period for senior citizens. So any individuals, I guess open enrollment periods, let's see, it starts in October. And so they are advertising constantly about, come, buy your Medicare Part C plan or Part D plan from us. You know, we're going to give you free gym membership. We're going to give you an electronic benefit transfer card for, healthy groceries. We're going to give you, over-the-counter drugs. And you'll see individuals whip out that EBT, that electronic benefit transfer. And as a Medicare beneficiary, hey, it's affordable and it's available to you, and, take advantage of it. And then we talked about in the text, as the authors talked about, Dewars especially, need does not necessarily equal demand. And that's where you end up with unmet needs. You either have unmet needs or, overutilization, and a lot of it, it's asymmetric information, it's level of access, it's a consumer's income level. All of those drive need and demand, because need to me implies there is a rationale for going to the doctor. Demand means I have decided to seek health care and I am capable of paying for it. So demand is typically consumers satisfying a desire to seek a good or service and having the capability and the willingness to pay for that good or service. So that's where you end up with a lot of issues in healthcare is you may have individuals that have a need to go to see the doctor, but they don't have the financial wherewithal to make the payments. So that, going to end up with unmet needs. Or the flip side of that, you've got individuals maybe on a subsidy program that have no financial requirements to seek health care, and they're going to be overutilizing. Or individuals with a zero copay, or even a $5 or $10 copay. Those copays are low enough that individuals will end up overutilizing healthcare goods and services. The government is established parameters in such a way that the free market does not really efficiently allocate or equitably allocate goods and services among the consuming population. Doctor-patient relationship, and we talked about it, it's a principal-agent problem. And, when you go in to see your doctor, you don't know what the doctor's contract is with the health plan. You don't know what, the profit motive for that individual is. Some providers just want to keep members happy. It's like, they want to meet members' expectations. And I've had primary care docs in the past that I would go in and, we'd talk for a few minutes, and I'd say, well, it seems to me like I need to be on this medication. The doctor said, yeah, that's what I'm going to prescribe for you. I'm not sure that's what I want, but he or she is trying to keep me happy in that sense, or in that situation. And that's probably not where you want to go when it comes to healthcare. And if you look at price elasticity, the price elasticity for healthcare goods and services is going to be negative. And it's going to be negative because of the law of demand. Demand curve slopes downward. Price goes up, quantity demanded does what? Goes down. Price goes down, quantity demanded of a good service goes up. So that's why the price elasticity, and when we talked about price elasticity, again, that may have been chapter 4, maybe. When we talked about price elasticity, the price elasticity of demand for healthcare goods and services, it's going to be negative. And it's going to be negative because of the lower demand. Just like the law of supply is going to have the price elasticity of supply is going to be positive. Higher prices, providers are willing to bring more goods and services to the market. The insurance companies are, and when we talked about insurance, we talked about insurance companies being there to transfer financial risk for a price. Arrow's article talked about it. Dewar's articles have, some of those chapters have talked about it. They are there to transfer the financial risk for individuals consuming healthcare goods and services. We're always, as a consumer, concerned about cost, personal risk of disease or illness, uncertainty of the treatment plan we're going to get. We don't know about the quality of doctor we get. Even when you get there, sometimes we have trouble determining what the quality of that physician is. And when we're talking about healthcare, and the healthcare market, the insurance market for healthcare, you talk about, of us in the market, which one of us are optimizers? Remember the 3 pillars of economic thought: opportunity cost, self-interest and optimization, decisions at the margin. Which of us are optimizers? I'm an optimizer. I'm optimizing as a patient. I'm optimizing my utility. I'm optimizing my benefit and satisfaction from going to the doctor. If you're a physician, you're optimizing profits. You want to optimize total revenue. You want to minimize total cost. You want to maximize profits. If you're a payer, especially a private sector health plan, it's the same thing. They're trying to minimize costs, trying to maximize revenue by selling healthcare benefit plans to employer groups. And at the end of the day, they want to maximize profits. They've got shareholders. Think of United, think of Aetna, think of Centene. They've got shareholders they're responsible to. So where, you know, all of us are optimizing some kind of a functional relationship. And again, that's why self-interest and optimization is such an important pillar to economic thought. And when you talk about insurance, and they touch on it, I think Dewar touches on it briefly. Employers, and I think in her text, it's since like, what'd she say, 1950, health insurance has become more and more of a benefit or part of your benefit plan. And, you know, employers provide health insurance because they want to attract individuals. That's what most people think. They look at it and said, oh, this is my part of my benefit plan. I've got a real good, you know, insurance benefit. I've got, you know, 401k. I've got disability. I've got some other, you know, vision, dental. I've got all of these benefits rolled up into my, I've got, you know, vacation days and sick days. That encompasses my benefit plan. But one thing that I think Dewar pointed out was employer groups also provide health insurance to employees, not just to attract and keep good employees and keep employees healthy, but it's a tax benefit. There are some tax, you know, some tax deductions associated with providing health insurance benefits to employees. And you have issues with healthcare contracts, and we talked about it: moral hazard, adverse selection, and government intervention. And government intervention, again, comes in when there's a market failure or when there's a perceived market failure. But even before the government comes in, at least in the state of New York, health plans have to take their benefit plans and their pricing structure and send it to Department of Health and the, you know, Department of Financial Services to get their blessing on it before they can roll it out and sell it to employer groups. You know, government playing in the sandbox, wanting to make sure there's, you know, equitable and value for the health plan and those individuals that are going to consume that health plan. So the government intervention is also an issue, along with, again, moral hazard and adverse selection. And then, you know, we talk about in the text, and, you know, we've talked about it, I'm going to say ad nauseum, but total revenue is equal to the price times the quantity. Total cost is also equal to the price times the quantity. There's a huge bunch of payers in the marketplace. And when you talk about it, it depends on how you look at it, you know, who's the 800-pound gorilla in the room. If you look at it by revenue and you pull it up on the internet, you're probably going to have United and some of your private insurance plans, you know, as far as revenue, they're the huge payers in the healthcare space. But the huge payer in the healthcare space, as far as dollars going out the door, is probably going to be CMS, Medicare and Medicaid, because even these private healthcare entities that have Medicare Advantage plans, or they're playing in the Medicaid market, or they're playing in the TRICARE market or the VA market, they are receiving funds. If it's Medicare and Medicaid, they receive funds from CMS and then turn around and pay for your healthcare goods and services if you've selected them as your Medicare or Medicaid provider. It's the same thing with TRICARE VA. DOD or have, the Veterans Administration have paid these health plans to provide these goods and services. So DOD and VA are paying out of pocket, out of their budgetary constraints, and then the health plans are overseeing the provision of healthcare service to their population. Again, CMS, if you just think about, Medicare and Medicaid and all of that encompasses, they're going to be the 800-pound gorilla when it comes to money out the door and paying for healthcare goods and services. And when it comes to securing goods and services, if your monetary costs are, I don't say negligible, but if your monetary costs are acceptable to you as an individual, then it's the time value of healthcare services becomes important. Again, I'm going to spend between 2 and 3 hours from the time I leave home, get to the doctor's office, and get back. That's 3 hours of my time. And now I'm talking about opportunity cost of my time. There's 3 hours of my time I could have been doing something else with, and guaranteed would have enjoyed it a lot better. And then we talk about, total revenue. When you're a provider, and if you go out into the healthcare marketplace and you're working in a provider's office, especially if it's a fee-for-service provider's office, you're going to, when you're trying to calculate total revenue, it's going to be price times quantity, quantity being units of service, office visits, lab work, radiology, physical therapy, maybe some behavioral health stuff. That's how you calculate total revenue. And I've talked to doctors in the past that say, my total revenue ought to be a lot higher than it is. I spend too many hours in the office. Number of hours you spend in the office doesn't really have a thing about, to do with your total revenue, unless you can see more patients by staying in the office more. So, but again, at the end of the day, it's total revenue is going to be price times the quantity of units that you provide while you're in the office, not so much the total number of hours that you're there in the office. And then the last couple of things, as we get older, as we age, our health status just depreciates. And the example they had in the text is like compared it to a piece of machinery. If you didn't maintain the piece of machinery, it depreciates faster. And if we don't manage our health status as we get older, we depreciate, it just depreciates faster. You can, unless you're, in Hollywood and, have unlimited funds and can afford a lot of plastic surgery, you may look good, but you're still not too sure about, what your health status is. So don't get confused between plastic surgery and health status. They're not necessarily correlated. And, we want to manage our depreciation of our health status. So again, if we maximize our health status, we should be going to the doctor fewer times. We should demand fewer healthcare goods and services. I try to manage my health status. Doesn't make me look any better, but I feel healthier and I'm going to the doctor a lot less than if I didn't manage my health status. That's going to wind up your review. Hope everybody does well. If you've got any questions or have any comments, don't hesitate to reach out to me. And the next time you see me, we'll be jumping into chapter 6 of Dewars text. Enjoy the rest of your day. Thank you.